Today we are going to see about musculoskeletal physiotherapy perspectives in the UK. So, what is the idea of this presentation? Is I'm not going to say which is right or which is wrong. We will see much of the views how a musculoskeletal physiotherapy is seen in different countries. So, for example, when we talk about our India or working in any of the Asian countries, so the way of treatment, the way we see the musculoskeletal physiotherapy is going to be the same. But how it differs when we work in a different setting or different institute or a different country, that varies. So it's not something like right or wrong. So which side you stand? So to me, it looks like 6. To you, it looks like 9. So that's the point here. And we'll see a little bit on the outcomes. So that is evidence-based practice in musculoskeletal physiotherapy. And I'm very sorry that I'm very particular about MSK because I'm not sure about a neurological or pediatric or cardiorespiratory physiotherapy. So I've given examples with my own discipline. So if you have any questions in the end of the sessions, we can discuss, and I'll try as much as possible to answer your questions. The second one is multidisciplinary approach, and the third one is advanced practice roles, and fourth is patient-centered care. The next one is access and service delivery, digital health and innovation, preventative and public health role, challenges and opportunities, and future directions. So the only one thing I would request is when we go through certain, like I'll go through a few slides. I want some answer from your side just to make sure whether you are connected with me. So make sure I'm not talking on my own. Is that okay? Is that okay for you?
Okay, sir.
Perfect. Right. The first one is evidence-based practice. So what is the emphasis on research? Why evidence-based practice is important? The UK has a strong focus on integrating evidence-based practice in musculoskeletal physiotherapy. Physiotherapists are encouraged to use the latest research and clinical guidelines to inform their treatment plans. This approach is supported by the organizations like Chartered Society of Physiotherapy and National Institute for Healthcare and Excellence. In short, we say as NICE. How we compare? Let's see what actually it works in our country. So in India, we say as MIAP, that is membership in Indian Association of Physiotherapists. So if you are a registered member of MAAP, so meaning professionally you can practice physiotherapy. That's how it works in our country. How they see here is, first you need a registration with HSPC, that is your Healthcare Professions Council. So that is a regulatory body. What is a regulatory body? Regulatory body is a person who check whether your qualification is right, whether you have completed your basic physiotherapy degree. It can be your master's degree or your PhD degree, and how is your clinical postings, hours of clinical posting, everything. And HCPC will have a lot of profession inside, like physiotherapist, they will have occupational therapist, they will have speech therapist, language therapist, art therapist. So they have 10 or 15 professions in HCPC. The role of HCPC is to give you a license to practice in UK. That's all. It's not in physiotherapy. It is a license, and the regulatory body will confirm, yes, so and so person studied here. The qualification is perfect. The language is fine. So that is the job of HCPC. Then you need to register with CSP, that is Chartered Society of Physiotherapy. This is a professional body. So as a physiotherapist, we need to register with CSP to practice as a neurological physiotherapist, a pediatric physiotherapist, or our own field. So in general, as a physiotherapist, you need to register as a CSP person. If you ask about a licensing pattern of SCPC, that is the regulatory body, you can get license from any part of the country. You can even do licensing from India. That's not an issue. But if you want to get a registration with a professional body, that is CSP, then you should be in the country. So if you're working, not working, that doesn't matter. You should be inside the country to be a member of CSP. Every CSP is guided by NICE guidelines. What actually is a NICE guideline? NICE guideline is a standard guideline by the government. So for any type of MSK treatment, that will give you an overall idea about any particular condition. For example, I'm a lame person. I don't know anything about physiotherapy, but I have arthritis in my knee. So I can get into NICE. I can see what are the things I can do for my osteoarthritis of the knee. It will give me some basic idea what is do's and what is don'ts. It will not explain you anything about physiotherapy, and it can explain you about some basic medications, how to prevent, how to move, how to walk. There is some guideline. This NICE guideline can open only in this country. So you cannot, even if I send you the link, you can't access from our country because it is restricted and it is used only within this country. And we talk about CPD, that is continuous professional development. Physiotherapists in the UK are required to engage in ongoing professional development, ensuring they stay up to date with the latest evidence and techniques in musculoskeletal care. What is CPD is, if you are working in a clinical physiotherapist or if you are working in a clinical site, so sometimes they go for audit like 3 years or 4 years, they go for an audit. They randomly pick the physiotherapist from one of the hospital. They will ask you what you have done to uplift your knowledge, what you have studied, what you learned, something to uplift your current knowledge. It's not necessary you need to do a course. It can be a certification, or sometimes it can be online learning, or something like it is a self-directed learning, that I read some journals, I read some articles, I have some idea about this, I have some idea about this treatment techniques. So that's fine as long as you learn something, that is counted as your points of CPD. And CPD points should be there to continue as a physiotherapist because they randomly check everybody. So it's not by the institution as itself, it is generally selected by the government for the CPD. What is a multidisciplinary approach? It is a collaborative care and a primary care of integration. Collaborative care is musculoskeletal physiotherapy in UK often involves a multidisciplinary approach where physiotherapists work closely with other healthcare professionals such as orthopedic surgeons, rheumatologists, pain specialists, occupational therapists. If you ask how this works, I don't get an idea about this collaborative care. So how we work in our country, the patient goes to orthopedician, the orthopedician refer the patient back to the physios. Can you please do this exercise or this particular treatment? So something like that. That's how it works. But how it works here is when a patient comes to you, and let's say I'm seeing him for a knee pain. When I'm assessing a knee pain, I'm getting to know that he's having a plantar fasciitis or something with his infection in a grade 2 or something. I can't neglect him just like that. I can say, no, this is not my area. I'm not going to treat you. This is not how it works. I need to collaborate with a podiatrist. So I make a referral to a podiatry team saying that I have seen this gentleman of this particular age with so and so issue, and currently he is having a problem in his grade 2. Can you please access biomechanically or with walking or insoles, whatever it is? The podiatrist will pick the form from you and they will do an assessment. They will do whatever necessary for the patient and they will hand over back to you, and you are treating the wounds and the phase is going on, and you are treating him for a few months of time and he is not getting better and the pain is still the same. Then what we do is, then we write a letter to the orthopedic surgeon. So can you please see, I have done all these things, I have treated all these treatments, it's not working for him, still the pain is same, can you please help? So for your second opinion. So then the orthopedic surgeons will say, okay, we'll go for a second opinion. And if you feel that is something like a smaller joints pain, it is something related with a rheumatology thing, then it's not the job scope of mine, that is in MSK. So again, I'll be writing a referral to the rheumatology team. So you have a specialized rheumatology physiotherapist. They will be taking over this patient and they will do the treatment. So when they are doing the treatment, what I do is I'll discharge from my service. I'll say I have done my job, done with the knee, but I can't do anything with the fingers. It is a rheumatology. So I'm passing the patient. I'm handing my patient to the rheumatology team. So primary care integration is many musculoskeletal physiotherapists in the UK work within the primary care settings such as GP practices, allowing for early intervention and management of musculoskeletal conditions. We need to understand a setting called as primary care and secondary care. I hope I will not confuse you too much with technical terms, but I will try to simplify as much as possible. What is a primary care? Primary care is the first point of approach. Let's make it simple. That is primary care. What is secondary care? Secondary care is something you need a treatment in a hospital. So that is a secondary care. So here physios work in hospitals, they work in clinic, they mostly the MSK physios they work in primary care settings. What is a GP is a general practice. That's the place where the doctors, physios, everyone work. So if a patient is walking in, so he's coming with an issue with some shoulder pain. So automatically the patient is directed to the physio, not to the doctor. They will say you are something with musculoskeletal, you are going to physio, not to the doctor. You are entering the GP practice, I have a fever, vomiting, diarrhea, go to your doctor. So automatically they will split in the first instance your musculo and your musculo neuro, whatever it is, and you are getting into a general doctor. And the person in the primary care setting will go through some conditions, they will explain you and they will give you some exercise to try. They will ask you, okay, you have a shoulder pain, can you try these exercises? This is your issue. That's how it starts. Later, I'll go through some chat. I will explain you one by one, step by step, so you'll get a better understanding about that. And here, if you see that, so can I make sure, is this picture clearer for you? Is
Yes,
that
sir. Clear.
Thank you. So, so if you see the steps, so here we do the screening. So this is the area where the GP practice, they do the screening of the patient. They will decide whether the patient is going to a physio or the patient is going to a doctor, that is a general doctor. Then comes GP guided self-management. Then comes the primary care management, and then comes the secondary care management. So this is the place where I am working. I am working in a primary care management and diagnostics. So your patient present to GP with a musculoskeletal or an orthopedic disorder, and you are checking for the serious pathology. Normally here we use the terms called as red flag signs. If you see different types of flags in musculoskeletal physiotherapy, you can see like an yellow flags, that is something to do with mental health, red flags, that is something to do with your general health. So you have the blue flag, something for occupational health. So you have different flags. You have orange flags, I'm not sure what is orange flags, but we have different flags. In serious pathology, if I see a patient with back pain has a cauda equina or a trauma, let's say an accident, we are referring the patient directly to A&E, that is accident and emergency. Go to accident and emergency, not to a physio. I'm not going to do anything with you. Next, there is no serious pathology. Then it comes here. You can see the GP management of self-management user information leaflets. So the physio in the general practice, he'll say, okay, you have a shoulder pain. I'm going to give you some exercise and you're doing the exercise. And the patient comes to you after 2 months. I'm not getting better with any of the treatment. So he's not coping well. Then from the GP, the patient is coming to the primary care. This is the place where I work. GP, primary care management and diagnostics. And here, if you see here, if the patient is not getting better in our treatment, then we do a referral for diagnostic, referral for an X-ray, MRI scan, or a blood test. So if you need to referral for, you can see the podiatry, pain management services, rheumatology, acute services, we say, I think, okay, he will get benefited with this treatment. There is a service called as pain management services. Normally, a condition like fibromyalgia, you do whatever physiotherapy, they will not get better because they will complain of pain in every part of the body. Neck, what is your complaint today? Neck pain, then shoulder pain, then back pain, then knee pain. Sometimes hip pain and ankle pain. So we think everywhere it's painful for you. I think you will benefit from pain management. It's not from me, because I can't give exercise for each and every joint of your body. So I refer for pain management. So yeah, and it comes for diagnostic purpose. Here it is an important point. It's not something, if he is not getting better with the shoulder pain, I can't say, okay, you are going for a scan, ultrasound, or MRI. I need to give a proper justification why I'm referring this person for a diagnostic. If I say I'm referring this person for an X-ray, why? If I say I'm referring this person for an ultrasound, why? If I say I'm referring this person for an MRI, why? So when it comes for why, there comes your treatment. So you need to justify, I have tried this exercise, this treatment, it didn't work. I tried this one, it didn't work. So there will be a senior physio team. They will check whether you have done all these steps. So they will tick, okay, he has done this. Then they will refer you for the diagnostic. They will not say directly, okay, go and do your X-ray. No, there will be somebody in between, a team in between to check everything, and after that they'll give a green signal. Yes, you can go for that. And if you can see the next one, a referral scientific gateway with required clinical information, and you can go for a surgery or a specialist. So we need to write a letter to the consultant, and I can't ask them to do a surgery. I can say the MRI says this is a grade 2 tear of ACL or rotator cuff fracture, but I can't say the consultant you need to do a surgery for this. So I will escalate to my higher team, and the higher team will escalate to the surgery. And there is an interesting part. I will explain you in the next chart about that, how you grow as a physiotherapist from different stages. So physiotherapy is not considered only as a physiotherapy, how you are growing yourself professionally. Professionally, how I'm growing as a physiotherapist. You should, you will see and you feel, okay, I'm growing in my own field. So growing is not only about the salary. I won't say not about salary. We are working for, everyone is working for salary. So we won't say, no, I'm not working for salary. I won't accept that. Everyone is working for salary. We need to grow. At the same time, our salary should grow. I'm working hard, I'm not moving forward, still my salary seems no. That's not how it's working. So how you move forward in different stages, I will explain in the coming slides. So we have something called as advanced practice roles. So we say as FCP, that is called as first contact practitioners. The role of physiotherapist as first contact practitioners has been expanding in the UK. There is a largest demand in UK now. FCPs are physiotherapists who work in primary care setting and are the first point of contact for patients with musculoskeletal issues. What is the difference between a musculoskeletal physiotherapist and a FCP musculoskeletal physiotherapist, that is a first contact practitioner? You can assess the patient, you can diagnose the patient, and you can treat the patient, and you can do the same referral like a GP. You can write all the type of pain medications if you are doing NMP, non-medical prescribing course. If you are doing the NMP, you are eligible to give all types of pain medications. I'm not talking about cardiorespiratory or some other medication. I'm talking about your analgesic, your gels, whatever it is, cream, whatever it is. So all the pain aspects from the injection, these things if you're doing NMP. And if you see the next one as extended scope practitioners, so that is slightly advanced to this. ESPs are physiotherapists who have advanced skills and may take on roles traditionally performed by doctors, such as ordering diagnostic tests. You can prescribe medications, and you can even perform certain procedures. You can go for joint injections. So if you are completing your injection therapy course, you are eligible to perform injections. That is your extended scope of practice. That is still your higher level of practice. Next comes the four pillars of practice. Can everyone hear me?
Yes, sir.
Thank you. So, four pillars of practice. In four pillars of practice, if you see, we have four things. One is a clinical practice, second is facilitating learning, third one is leadership, and fourth one is evidence, research, and development. So, I have completed my bachelor's I'm completed my
Good day,
bachelor's
ma'am.
degree. I'm starting my
They will
career
connect
as
in
a
10 minutes, ma'am.
physiotherapist. I'm a new joiner. I'm starting my career as a physiotherapist.
Am I
So
audible, ma'am?
your focus will be more on the clinical practice.
They will
They are
connect in 10 minutes,
more
ma'am.
concerned about your knowledge. They are more concerned about your skill, behavior, and high quality healthcare is safe. That is the most important thing when you're starting your career as a clinical practice. You get some experience. Let's say you are working for 1 year, 2 years, 3 years, you are working for a few years, then they expect your clinical practice percentage is less and your facilitating learning is more. What is facilitating learning is more? That is how you train your junior physios, that is the new coming physios, and how you are training the students in your posting. Normally in our country, when we go for postings, so our lecturers used to join with us to the hospitals. They will teach us the clinical stuffs, how you do a treatment in a neuro setting and orthopedic setting. But here, no lecturers will join the students. It is the duty of the government physios to train the students. So the lecturers will not join for the clinical posting. They will join only in Teams, Microsoft Teams. They will ask to the staff over the hospital, is my student okay? That's all. Then I'll see them after 4 weeks or 5 weeks of time. They will come back again. Is my student okay? That's all. They'll go back. So that is a big process. I'm not going to elaborate that. So facilitated learning is where you are training your newcomers, your colleagues, sometimes, most not sometimes, sorry, mostly your students. That is your facilitated learning. And you are working like 5 years, 6 years, 7 years, you are moving little bit to the higher level. They expect some leadership quality from you. So what is a leadership quality is, if a manager is on leave in a hospital, so how you are managing the team. Or for example, you are the senior physio and you have 5 or 6 juniors with you, and suddenly you have a patient with some serious spinal pathology. They don't know what to do with this patient. They are coming to you, they are asking you the help, can you help me? Then you are a responsible person to proceed. You need to check, you need to assess, and you need to confirm, yes, it is a serious pathology, yes, it is not a serious pathology. It's not only about the treatment, how you manage your team. Of suddenly 5 people working in a hospital, 3 of them feel sick, they are not coming for today, only 2 left in the hospital. So how you are going to manage the patients who are already booked with you? So you need to say rebook the patients with some other colleagues of you. Otherwise you need to take the responsibility of taking over your friends patients, your colleagues patients. You need to see them, and how you're managing that, that is your leadership. When it comes for evidence research and development, this plays a major role in your practice. When you start your career, evidence research and development is very little percentage. They won't ask you too much. Something like, they will ask you, do you read journals? So what is the current evidence for this treatment? Do you know anything? That is general. When you are going to the next level, facilitated learning, they'll be asking more how it applies, how it differs from the others. So once your growth goes higher and higher, when you're growing higher and higher, the percentage of your leadership, the percentage of your evidence research and development grows higher. So it's not everyone working as a physio. As physio, the term is physio. Musculoskeletal physiotherapist is a physio, but how it differs from a senior, junior, difference, how the difference made between the people is how the percentage is linked. So how there is something like a banding system. So they start from like band 2, band 3, band 4, band 5, band 6, band 7, band 8, and B. So band 8 and B is something like a managerial position. So for example, if you feel I'm not interested in a leadership, I want to get into some other thing, it's up to you. You can choose in facilitated learning as a student educator. You can choose your full, whichever field you like. So this is the red flags. In musculoskeletal physiotherapy, we see, as I said, we have red flags. I'm not going to read the definition for this. I'll just go with the bolded ones. So what are the trauma red flags? That is any recent trauma. So it is a fracture, go to accident emergency. It is not anything with the physio. Visible deformity, you are not sure, it is dislocated, go to accident emergency. It's not with MSK. If you find fever, illness, redness, warmth, and swelling, and if you feel that is something related to infection after a surgery or something, again you are going to refer them. Okay, it is infected. For after, I think I saw a patient of total knee replacement, it's just swollen just like that. and lot of bruises in the leg. So again, we say, get back to your consultant. We are not going to do any physiotherapy for you. And cancer related red flags, that is something like a significant weight loss. How you measure that significant weight loss? Something like 10% of your body weight. Last 1 month, I lost 10% of your body weight. There comes the question mark, why you lost 10% of your body weight within 4 weeks of time. So night pain, sometimes we say this word as an unremitting night pains with sweats. That is not something right for a person to get sweating, unremitting sweating. Sometimes even at the stage of menopause, you get sweating in the night time. That, so we are not going to get confused with that stages, but specific time, pain and sweats, then it triggers your mind something is wrong with this patient. And if there is a family history of cancer, and be very cautious, go through all the blood tests, check. And as I said, so it depends upon your band. So if I'm band 5, I'm not worried about this. Then no one will ask you why you didn't check this. No one is going to ask me. When I'm going moving to the specialist category, if I'm missing this, you are done. So that's your job to make sure you are screening everything. So this is a cancer related red flags. And neurological red flags, whether it is a progressive neurological deficits or bilateral neurological symptoms or loss of motor control. And if any neurological symptoms, again, we are, and that is the best part is, for example, if you suspect something like cervical myelopathy, let's say I'm suspecting a patient with cervical myelopathy. What I do is I get a hotline. So we give a call. So there will be a consultant there and you'll be talking to them. The best part is you will be given exactly 3 to 4 minutes of time. You are given only 3 minutes to 4 minutes. What is the name of the patient? What is the number? We say like Chi number, that is something like ID number. What is the ID number of the patient? What is the issue with the patient? And what red flags you have seen today? So you say 1, 2, 3, 4. The consultant will say, yes, send him to me. The consultant will say, don't worry, Ganesh, he's fine. So you need to explain him, so he will take 3 to 4 minutes to answer your question. You need to get prepared in a way. Okay, get prepared. I'm going to all this question to my consultant. Get ready, give him a call. He will answer 3 minutes. He will say yes, he'll say no. If it's no, you are clear, no need to worry. If he say yes, you need to make a letter, send him to accident and emergency. So that comes with your neurological red flags. Same goes with your vascular red flags, whether you have a pulsating mass in the shoulder or severe unexplained pain. So it depends upon the condition what you are. And systemic red flags, that is a persistent shoulder pain with systemic symptoms, pain not relieved by rest or activity, still it's painful, or cardiac related red flags. When it comes for cardiac red flags, they will report to your place in, I think you are not, they are supposed to report within 5 minutes. Yes. Yes. If you are seeing a patient and the patient get collapsed and you have an alarm bell, if you press that, within 5 minutes there will be a complete team from the hospital. What the thing is, I need to ring the number 222. My name is Ganesh, reporting from MSK Physiotherapy, ground floor hospital. That's all. Within 5 minutes the team will be there. So because they will alert everyone, so within 5 minutes the team will be there to check the patient. So for cardiac, no writing letter, no referral, nothing. If it is cardiac, next 5 minutes the team is ready there for the treatment. That's all. Once the team take over, your job is done. You are not doing physio. After that, you can write an email to the doctor. I have seen so and so patient. This patient got dizziness and shortness of breath and some cardiac issues, and there is an issue with the pacemaker. This team is taken by a medical. This person is taken by a medical team, and my job is done. And you are writing everything, and you are discharging him. So the letter goes to the doctor. Then it's their duty to take care of him. Once he is okay, then he'll be coming back to physio. Till then, you are free. So you are sending to the next team. Inflammatory red flags, that is morning stiffness lasting more than 1 hour or pain in multiple joints. So based on that, whether it is rheumatology or something with arthritis, normally MSK we do with arthritis, if it is like polymyalgia rheumatica or something inflammatory things, it's very difficult to treat. So they have a separate physiotherapy team for that. They have a lot of patients to treat them. So we do a referral to them. They will take over for the inflammatory red flags. So this one is a conclusion. It says about how this works, the red flags works. And patient-centered CAT, it is individualized treatment plan. Musculoskeletal physiotherapy in UK places a strong emphasis on patient-centered CAT with treatment plans tailored to the individual specific needs, preferences, and goals. This approach enhances patient engagement and adherence to treatment, self-management, Sorry, my system is updating. 1 second. Self-management and education. There is a focus on educating patients about their conditions, encouraging self-management strategies. This include teaching exercises, providing advice on posture and ergonomics, and helping patients understand how to manage pain and prevent further issues. This is something like a patient education. So it is something, once you achieve the goal, for example, I achieved a goal, I'm treating a shoulder pain and he got better. So I ask him, what is your next goal? He say, I want to get back into fitness. So okay, good. Any other thing? He say, I want to get back into swimming. So it's not something that it ends. I'm treating a patient, my treatment ends and your pain is fine, I'm not going to discharge him. He says my next goal is fitness. So when he say next goal is fitness, what we do is we make a referral to the closest sports center or leisure center. We say here leisure center, so we have the leisure center. We make a referral, so they have gym, they have swimming, they have sauna, hot bath, everything. So and so person looking for some fitness, please take care. So there are sports therapists working with them. They will pick this patient, they will train them for fitness, and their journey continues. So they are coming with the pain to a GP practice, they are coming to a physiotherapist in a hospital. We are treating them and handing over them to the sports center. The sports center people will continue the management. It is something like a good long journey for a patient. You start somewhere from pain and you are improving your health. So how the journey travels from, so you have doubt, like you need an assessment by a podiatry, rheumatology, something, just check with them, get back to them, then again moving forward. This is something like, it's not stopping, the care is not stopping, you're moving the person step by step to the next stage. So that is the patient centered care. So access and service delivery. So we have NHS. NHS is the National Health Service. There are different boards. So for example, you can work in different types of boards, but everyone is under NHS. That is the National Health Services. If you ask, there is no private. Yes, there is private sector. So the salary is high, private sector, same like our country. So private is something different from the hospital side. So private sector alongside NHS services, there is a thriving private sector for musculoskeletal physiotherapy in UK, offering patients quicker access to care and a wider range of treatment options in the private. And if you see the private sector, when it comes for the private sector, I'm not against certain types of treatments, but still, so how it works here. So when I came here, when I started my career, I was more interested in a lot of electrotherapy equipments. I thought, okay, what do you do? I say, like, I do ultrasound, IFT. But after coming here, I asked, have you done any ultrasound before? They said, yes, we used ultrasound in 1995. I said, very good. So have you used IFT? Yes, we used IFT in 2002. Very good. So any electrotherapy in this hospital? They say no. So everything is hands-on. Everything is hands-on. So nothing. So private sectors, yes, they do ultrasound. Our electrotherapy modalities. Uh, to my understanding, so there is no electrotherapy here. To my understanding, there is no electrotherapy. Everything is your hands-on skill. And telehealth and online resources. So the COVID-19 pandemic changed everything. Then they started with virtual consultations, online exercise programs, and management tools. So technology, so there is a lot of technology, wearable devices, motion tracking systems, apps, everything. And you can see the monitor patient progress and deliver the personalized care. And so I'm going to start a little bit about my topic. This is my master's in University of Dundee in Scotland. So before I start, is everyone with me? So motion analysis is a process used to evaluate, understand the movement of human body or a mechanical system. So motion analysis is a process used to evaluate and understand the movement of human body or mechanical systems. In the context of healthcare, sports, and physiotherapy, motion analysis is primarily used to assess, improve human movement, particularly for diagnosing musculoskeletal issues, optimizing athletic performance, and guiding rehabilitation. If you're a person interested more in biomechanics, if you say I'm interested in much in biomechanics or sports related, I think from my understanding, this University of Dundee is the first of its kind to start the 3D technology in doing a motion analysis in UK. and they have well developed sports lab. So I don't want to scare you with my pictures. That's the reason I made it small. So here you have anterior marker placement. So you can see the dots. These are the markers. These are the markers in the body. So when the markers is on when you're walking, so this is a sports lab. This is our sports lab, and so everything is with IRR. So here in base, this is a cone. This is for your walking. Can you see the square boxes here? This is a force plates. So you will be walking, running in this lab. So this is a gait lab. You can walk in this. So automatically this lab will record. When it records, this how the picture looks like. So this it goes for a stick diagram. So you can see the number 1 and 2, that is to calculate the heel strike on a force plate. So my project was something in walking on 3 different speeds and how it impacts the kinetic and kinematic things and how the potential and mechanical energy is used in a gait analysis. So this is a stick diagram and you have some formulas to work on. So how you measure, how you are taking forward with your study, that matters. So main key components of motion analysis is something with kinematics. So kinematics is a study of motion without considering the forces that cause it. It involves measuring the position, velocity, acceleration of body parts during movement. As I said, if you're interested in biomechanics, if you're happy with your maths and physics, then I will recommend. If you're not happy with maths and this is not your field, tools used is marker based system. So we use Vicon. I don't know anything about Qualisys. We used a Vicon system, markerless system, that is something like I said, like the white ones, and we have IMUs, the inertial measurement units. For you have a sensor that is attached to your body. And kinetics is the study of forces that cause motion. It includes analyzing the internal muscle forces and external forces, gravity and ground reaction forces acting on the body during movements. So what are the things we use? We use force plates, dynamometers, and EMG. I didn't use EMG for my study because I was looking for more of potential and kinetic energy. So I'm fine with the measuring with the cameras because I didn't go for any muscular pattern like in any leg movements, or you're working for any particular muscle, your hams or your quads, or in any particular muscle, your rectus femoris, semitoninus. Is there any particular movement? One of uh, my classmate, she did something on EMG because she is working on specific muscle, but she didn't do anything on other energy aspects. So she was working only on the muscular thing. So she used like EMG things. Sorry. And motion capture system, this is the one I used. So how you do a video analysis, how you do a 3D motion analysis of your kinematic data and kinetic data to provide a comprehensive 3D model. This can be used for your detailed biomechanical analysis. And when you have this system, when you learn this and you have this facility in a hospital setting, then it will be easy for you to assess the patient when you get a referral for motion capture things or gait analysis things. Data analysis is done by software, so no need to worry about this. So every setting, the university, the uni have everything softwares provided for you. So it will measure your joint angles, force distribution, muscle activation. But you need to give, or you need to set something. What are the things you are looking for it? I'm looking for a joint angle. I'm looking for a force distribution. That is done by you, not by the software. You need to pick what are the things, but you will get a guidance from your guide, project guide. So nothing to worry about it. And biomechanical models, advanced models, are used to stimulate and analyze a movement, helping to understand the relationship between a movement patterns and underlying the musculoskeletal issues. Sometimes without using the patients, you can use models, dummies for the project. To me, I'm not much interested with the dummies. So I selected some random participants, my friends, and some of the students from the uni as a model. Sometime I think I have 2 of my lecturers as my models. So you can do that way. And what is the application of motion analysis is the clinical assessment that is mainly for your gait analysis. Why we use this one? What is the point of studying motion analysis? Mainly for gait analysis and post-surgical rehabilitation when you are rehabilitating a patient, whether he is improving, not improving, post-surgical rehabilitation, sometimes for orthotic and prosthetic designs. So you can use this motion analysis. So it's not necessary that you need to be a physiotherapist to do this particular course. You can be from Bachelor of Physiotherapy, or you can be Bachelor of Occupational Therapy, or you can be from Biomedical Sciences background, or you can be Bachelor of Sports Therapy. So there is no restriction to learn as long as when masters comes. The masters is open for everyone. So something related to your our age. So it's not that a physiotherapist. I studied Bachelor of Physiotherapy. I should study only Master of Physiotherapy. So the options is open for you, whichever choice, whichever field you like, you can move. So from ortho I jump into neuro, you can do that. From neuro I jump into ortho, you can do that. You are most welcome. So I'm shuffling between the areas. You are most welcome. You can do whichever field you like. And what are the benefits? It gives you a precise objective assessment and your personalized care and early detection and enhanced performance. The performance is something really good. And the preventative and public health role. So we have a community programs. So musculoskeletal physiotherapists in UK often play a role in community-based programs aim at preventing musculoskeletal conditions, particularly in high-risk populations such as older adults. Because when they organize a community program that comes from the National Health Services team, so you'll be part of the program, you'll be giving a lecture about like hip pain. So how the hip pain is affecting elderly population. You will get lots and lots of participants. They will come, they will ask you, they will discuss with you. So how I can do physio, how I can do this exercise. So that is something really good. The best part of the thing is once you tell these exercises, I'm not saying everyone. So mostly the people, they religiously follow physiotherapy. If my physiotherapist say to do this particular exercise, mostly I'm saying mostly with a question mark, I'm not putting 100%, they will follow religiously that particular exercise. They say I have tried this is it is working. At the same time they will say I tried this one, it's not working for me. And workplace health, there is also a growing emphasis on workplace health with physiotherapists involved in designing ergonomic interventions. That is, if you want to work in a company, delivering workplace assessment, that is an occupational health physio. So you can be a part of some like IT sector, any company where you will be doing an occupational health physiotherapist, or you are working with the Ministry of Defense, you can be an occupational health physiotherapist for the people working in Ministry of Defense, and providing education to prevent work-related musculoskeletal disorders. So the field is vast. You can choose the area where you want to step on. Challenges and opportunities, workforce demand. There is a high demand for musculoskeletal physiotherapists in the UK, particularly in NHS, that is a National Health Services. However, challenges such as recruitment, retention, workload management remain. So there are some ups and downs. So funding and resources, like many healthcare sectors, musculoskeletal physiotherapy faces challenges related to funding, resource allocation, impacting service delivery and access. This is something just to be on the safer side. But mostly you get, if you want to work in clinical at the same time you want to move towards your academic career, you can do. You are in academic and you want to develop some interest in clinical, yes, you can do. You want to do in a government and you want to start your own clinic, yes, you can do. You will say, I will work only 3 days a week, yes, possible. I want to work only 1 day a week, yes, possible. Everything is possible. The flexibility in your own field. The future directions, innovation in treatment. The future of musculoskeletal physiotherapy in the UK is likely to see further innovation in treatment modalities, including the use of regenerative medicine, robotics, and advanced rehabilitation technologies. Public health integration, there is a growing recognition of role of musculoskeletal physiotherapy in broader public health initiatives, particularly in addressing the burden of chronic musculoskeletal conditions and promoting physical activity. Thank you.